everybody, I'm Chris Morosky, and the title of this video is Ovarian Cancer, and it is part of our Health System Science conference series. The goals and objectives of this video are as follows. Develop an organized approach to the classification of ovarian neoplasia. Describe the workup of an adnexal mass, including the usefulness of specific tumor markers. Discuss cancer staging and treatment options for advanced stage ovarian cancer, and review how the health system science topics of quality improvement and clinical research help to prevent postoperative pulmonary embolism in cancer patients. In this video, we will follow along with our patient, AE. Let's learn a little bit more about her in the next slide. AE is a blank-year-old Caucasian null-gravid female who presents with a 3 months history of pelvic pain, abdominal bloating, and swelling in her pelvis. She has no vaginal discharge or irregular bleeding. She has no fevers, chills, or GI symptoms. What is your differential diagnosis if she is found to have an adnexal mass? More specifically, what will be your most likely diagnosis if her age was 15 years old, 35 years old, or 65 years old? Before we move on to our complete differential diagnosis, let's learn a little bit about the parts of the ovary and how these can give rise to neoplasia. When thinking about the three main parts to the ovary, it is helpful to use an analogy with an apple. Apples have a surrounding skin, they also have their fruity pulp, and in the center they have small seeds. It's a bit of an oversimplification, but the ovary can be thought of in the same basic way. There is a surrounding surface epithelium. In the middle is a somewhat fibrous stroma with other hormone-secreting cells. And lastly, there are the germ cells, or the eggs. All of these can potentially give rise to neoplasia. With this in mind, in the next slide, we'll describe an approach to thinking about the ovary in these parts and how you can come up with a way to organize tumors arising from the ovary. Here we see a simple table that will help with an approach to ovarian tumors. On the left, we have the three parts of the ovary, the epithelium, stroma, and germ cells. And across the top, we have different types of neoplasia: benign, borderline, and malignant. Benign tumors have no possibility of being cancerous, and malignant tumors are obviously cancer. Borderline tumors are those in between which have some possibility of persistence or metastasis, or eventual conversion to a malignancy. We'll start with the most left-hand column and then progress across the rows and learn about the different types of tumors that arise in these parts of the ovary. So first, starting with the epithelium, benign growths here are commonly serous or mucinous cystadenomas. The borderline tumors include borderline, serous, and mucinous cystadenomas, and then there is the malignant epithelial ovarian carcinoma. When looking at the stroma, the benign tumors here are fibroma and thecomas. All the way to the right, the malignant tumors here are granulosa cell tumors and Sertoli-Leydig cell tumors. I've included these also in the borderline category because there are less aggressive versions of these tumors that act more like a borderline tumor. Finally, moving to the last row, the germ cells, a very common benign tumor that arises from the germ cells is the mature cystic teratoma, also known as a dermoid. Again, moving over to the right malignancy column, here you will find the germ cell tumors of dysgerminoma, yolk sac tumor, and choriocarcinoma, all of which are considered to be malignant. In the borderline category is immature teratoma. While these more often are malignant, there are less aggressive versions of this that can be considered to be borderline. Okay, now with all of this in mind, let's think about what this would look like in terms of a differential diagnosis by age group for ovarian neoplasia. In this slide, we break down the more common ovarian neoplasia growths or tumors based by age group. In the first age group of 15 years old, the most common growths in the ovary are going to be functional cysts, and these would include follicular cysts and corpus luteum cysts. Also common in this age group is ovarian torsion, which will prevent with an ovarian mass, but also significant pain, as well as tubo-ovarian abscess, which will commonly present with pain as well as fevers. Just below this category, I've included a few other tumors. These are common in all age groups, but they definitely appear here also in our younger populations. These would include the germ cell tumors, as well as granulosa cell and Sertoli Leydig cell tumors. There is some overlap of these younger patients having similar tumors to our 35-year-old category of patients, specifically the functional cysts, tuber-ovarian abscesses, and even ovarian torsion. But in the age group of 35 years old, you also need to think of some other conditions which are less common in the 15-year-old patient. This would include endometriosis, as well as dermoid cysts, or the mature cystic teratomas. These would be more common in this age group of women. Finally, in our older age group of 65-year-old women, we would want to think about these other tumors as well. These include the mucinous and serous cystadenoma, which are more common in this age group, as well as the stromal tumors of fibroma and thecoma. I point out Meg syndrome here because this is always on your exam, and everybody loves to ask medical students about this. Just remember that Meg syndrome is a patient who presents with a fibroma in the ovary, ascites, and pleural effusions. Interestingly, the ascites and pleural effusions resolve with removal of the fibroma. They're not exactly sure why this happens. Lastly, in this age group, we need to be thinking about epithelial ovarian cancer. Alright, and before we return to taking care of our patient, AE, I just want to review very briefly the specific tumor markers that they're going to ask you about in the exam when it comes to germ cell tumors and other stromal tumors of the ovary. These tumor markers are not always greatly elevated in these tumors, but they usually are. There's also some overlap between these tumor markers in the different tumors. But for the most part, if you got a multiple choice question, these are going to be the tumors that you would want to associate with the tumor marker. So let's go over them. For dysgerminoma, the tumor marker is lactate dehydrogenase, or LDH. For choriocarcinoma, the tumor marker is human chorionic gonadotropin, or HCG. For the yolk sac, or endodermal sinus tumor, and those are the same thing, the tumor marker is alpha-fetoprotein, or AFP. Granulosa cell tumors will secrete inhibin A or B, estradiol, and anti-Mullerian hormone, or AMH, and Sertoli Leydig cell tumors will secrete testosterone, androstenedione, and dihydroepiandrostenedione, or DHEA. Alright, I just helped you get one more question right on your shelf exam. You're welcome. Now let's get back to finding out about our patient, AE. Okay, so it turns out AE is a 65-year-old postmenopausal female with an adnexal mass. Here are her histories. Her previous obstetrical history, she's never been pregnant. Her previous gynecologic history, she has no abnormal pap smears, no STDs, and she is single. Her previous surgical history includes an open appendectomy. Her previous medical history includes migraine headaches and rheumatoid arthritis. She takes sumatriptan and tofacitinib for both of these. She has no known drug allergies. She's a never smoker. She drinks no alcohol and uses no drugs, and she works as a grocery store cashier. Her family history includes a mother who died from a stroke and a father who died from a myocardial infarction. What are your next steps in this patient's management? Alright, so after finishing up your history of present illness and your review of systems, you're ready to move on to the physical exam. This patient would warrant a fairly comprehensive physical exam. Let's see what was performed in the next slide. Here is AE's physical exam. Vital signs. She is 5 feet 6 inches tall and 156 pounds. Her blood pressure is 126/74, her heart rate is 74, respiratory rate is 18, and she is afebrile with a temperature of 98.9 degrees Fahrenheit. On general appearance, she is alert, oriented, no apparent distress. Her cardiovascular exam is regular rate and rhythm with a normal S1 and S2. Her lungs are clear to auscultation bilaterally. Her abdomen is soft, non-tender, and non-distended. She has no guarding or rebound. There is a firm pelvic mass halfway between the pubic bone and the umbilicus. On pelvic exam, she has normal, female, external genitalia, a normal vagina and closed cervix. On speculum exam, there is no blood in the vagina. On bimanual exam, she has no cervical motion tenderness. There is a firm pelvic mass filling the pelvis, which is more on the left adnexa than the right. It is non-tender. On rectal exam, there is no intraluminal masses, and the adnexal mass is palpable rectally as well. In a 65-year-old postmenopausal patient presenting with a palpable adnexal mass, what follow-up additional radiologic and serum testing would you want to perform? Let's take a look and see what was done. The first thing that was ordered for our patient AE was a pelvic ultrasound. You can see the results of one image here in this slide. This is clearly a transvaginal ultrasound as determined by the shape of the transducer in the top middle part of the screen. Just below the transducer is a normal-sized postmenopausal uterus that looks pretty normal. However, below the uterus is a large mass in the cul-de-sac of Douglas protruding into the pelvis and upper abdomen, similar to what was appreciated on physical exam. This adnexal mass has a cystic or fluid component, as can be seen in the middle portion of the ultrasound, and denoted by the hypoechoic fluid. It also has solid components, as can be seen here in this slide, as denoted by the hyperechoic material. Importantly, the shape of the solid masses includes these nodules, which are very concerning for malignancy. Also, there is a severely thickened wall to this ovarian mass. The measurement of this wall is 1.6 centimeters. This also is concerning for malignancy. Here in the slide, we can see that the patient had a CA-125 level drawn, and it's resulting at 917. This is elevated and not normal. In this next slide, we'll learn a little bit more about CA-125. CA-125 is cancer antigen 125. It is also known as mucin 16, and it is a member of the mucin family of glycoproteins. Mucin 16 is a component of the female reproductive tract, the respiratory tract, and ocular surface epithelia, where it acts as a lubricating barrier. The normal cutoff value for CA-125 is 35 kilounits per liter in postmenopausal women. It can be elevated with metastatic ovarian cancer, but it's important to note that it can also be elevated with other conditions such as endometriosis, menses, cirrhosis, pelvic inflammatory disease, fibroids, and many other things. Due to this, CA-125 has failed to become a reliable screening test for ovarian cancer. However, when severely elevated in postmenopausal women, such as our patient AE, presenting with a palpable adnexal mass, which appears very abnormal on ultrasound, this increases the suspicion that her pelvic mass is a malignancy. Okay, now let's move on to the treatment options for our patient AE. Again, our patient AE presented with a 3-month history of abdominal bloating, pelvic pain, and swelling in her pelvis. She was found to have a palpable adnexal mass, which was concerning on ultrasound for malignancy, and she had a severely elevated CA-125. Let's take a look and see what treatment options we would want to discuss with her. In this slide, we will briefly review the overview of treatment of ovarian cancer. Similar to endometrial cancer, ovarian cancer is staged surgically. Epithelial ovarian cancer unfortunately spreads throughout the peritoneal cavity very often by the time of diagnosis. The goal of surgery for ovarian cancer is to remove all of the cancer. More specifically, the goal of surgery is to remove all of the visible cancer. The term optimal debulking refers to removing all of the cancer so that the tumors that are remaining inside the peritoneal cavity are all less than 2 centimeters in size. Neoadjuvant chemotherapy is used if the surgeon believes that it is not possible to remove all of the tumor so that what is remaining is less than 2 centimeters in size. If prior imaging suggests that all of the cancer cannot be successfully removed, patients have better outcomes with neoadjuvant chemotherapy. Keeping this in mind, our patient really had imaging that showed that the majority of the tumor appeared to be in her ovary, so she is going to be brought to the operating room. Let's discuss the surgical consent with our patient AE. In terms of planning surgery for ovarian cancer, the approach is usually by laparotomy. This allows the surgeon to explore the entire peritoneal cavity to assess where the tumor has gone and to remove it from all of the organs. For patients where small masses with limited spread is likely, the surgery can be done either laparoscopically or robot-assisted laparoscopically. What must be performed for metastatic ovarian cancer is a total hysterectomy, bilateral subhinguoophorectomy, omentectomy, removal of all visible tumor as we mentioned before, and usually there is some degree of pelvic and periaortic lymph node dissection because, again, ovarian cancer is very commonly spread to these lymph nodes. Okay, in this next slide, our patient has undergone all of these procedures, and here are her histopathologic results. Here is AE's histopathology report. The diagnosis is left ovarian papillary serous adenocarcinoma. The ovarian adenocarcinoma involves the serosa of the uterus and the right ovary. She has multiple omental implants, with the largest up to 3 centimeters in diameter. For her pelvic lymph nodes, 5 of 22 are positive for metastatic adenocarcinoma, and for the periaortic lymph nodes, 3 of 8 are positive for metastatic adenocarcinoma. What is her stage? The old and new FIGO staging for ovarian cancer is overwhelming. This slide would drive almost anybody crazy. Most medical students are not going to be required to memorize this to such fine detailed degree. What we do know is that our patient AE's ovarian cancer has spread to the pelvic lymph nodes and throughout the peritoneal cavity. And so she's actually not stage 1 or stage 2. So let's move on to the next slide. Looking through all the options, it is apparent that the patient has positive retroperitoneal lymph nodes and metastasis beyond the pelvis. So this is going to make her stage 3. She's not stage 4 because she doesn't have evidence of distant metastasis outside of the peritoneum. Going through the list of stage 3, it eventually becomes obvious that she has stage 3 disease. She has macroscopic, extrapelvic peritoneal metastasis greater than 2 centimeters, such as the 3 centimeter nodule on her omentum, and she also has positive retroperitoneal lymph nodes. AE's diagnosis is stage 3 papillary serous ovarian adenocarcinoma. Alright, so let's go on and discuss adjuvant treatment and see what happens to our patient AE. AE initially does very well from her surgery. The plan is for her to begin 6 cycles of carboplatin and paclitaxel chemotherapy. Unfortunately, 2 weeks following her surgery, she presents to the emergency room with acute onset of shortness of breath and chest pain. She suffers from a massive pulmonary embolism and dies in the intensive care unit later that evening. What changes to the healthcare system could have prevented this patient from dying from a pulmonary embolism? In this next slide, we will one more time look into the concept of health system science to determine how this death could have been prevented. Again, health system science is the third pillar of medical education following basic science and clinical science education. The core domains of health system science are healthcare structures and processes, healthcare policy, economics and management, clinical informatics and health information technology, population health, value-based care, and health systems improvement. The cross-cutting domains, which are just being talked about in this video, include leadership, interprofessional education, evidence-based medicine, ethics, and scholarship. When thinking about how our patient AE's death from venous thromboembolism following surgery for her ovarian cancer could have been prevented, what portions of health system science have been figured out to prevent this from happening? Here in this video, we will discuss the core domain of health systems improvement and the cross-cutting domain of evidence-based medicine as a way that we figured out how to prevent deaths like this in patients such as AE. As a background to venous thromboembolism in cancer patients, we now know that the risk of VTE in patients with cancer is greatly increased, and this is particularly true in patients who undergo abdominal surgery for their cancer. The transition to provide patients venous thromboembolism prophylaxis initially just during the perioperative period, and then extending this to the immediate postoperative period, and then finally extending this to the prolonged postoperative period, took a combination of quality improvement measures and clinical research to eventually figure this out. This all really began in the late 1990s and is now routine practice. One of the landmark studies was published in the New England Journal of Medicine in 2002 and is presented here. The title of this study was Durational Prophylaxis Against Venous Thromboembolism with Enoxaparin After Surgery for Cancer. In this study, the investigators enrolled patients undergoing abdominal surgery for different types of cancers, including female reproductive cancers. All patients were given enoxaparin prior to their surgery and for the first 10 days following the surgery. After this, patients were then randomized into 2 groups. One group received placebo, and the other group received enoxaparin for a total of 4 weeks of treatment. The primary outcome was all venous thromboembolism. Here you can see their primary results in Table 3. Let's take a look more closely. When looking at the primary outcome of all venous thromboembolism, this occurred in 12% of patients who received postoperative placebo. Venous thromboembolism only occurred in 4.8% of patients who received extended postoperative enoxaparin. This was a significant risk reduction of this outcome of 60%. And looking at this at 3 months, there are similar outcomes. The placebo group had 13.8% of patients with VTE, and the enoxaparin group only had 5.5% of patients with VTE. This again was a significant risk reduction of 60%. Due to studies like these, our ovarian cancer patients now go home with weeks of postoperative anticoagulation to prevent the catastrophic complications of VTE as seen in our patient AE. I'm not that old, but I did start medical school when this study was published, and I can tell you I saw this practice change during my residency, and it is now common practice, thanks to the health system science concepts of quality improvement and evidence-based medicine. Alright everybody, that is a wrap on this video. Let's go over our goals and objectives and see how we met them. The goals and objectives of this video were as follows. Develop an organized approach to the classification of ovarian neoplasia. Describe the workup of an adnexal mass, including the usefulness of specific tumor markers. Discuss cancer staging and treatment options for advanced stage ovarian cancer. And review how the health system science topics of quality improvement and clinical research help to prevent postoperative pulmonary embolism in cancer patients. Great job, everybody. Thanks so much for watching this video. Good luck with all of your studies, and we'll see you around, everybody. Bye-bye.